This is Jonathan Sellen, and I will be presenting our Chapter 326, Assessment and Treatment of Benign Intradural Extramedullary Tumors, with my co-authors, Drs. Tatsui and Rines. We will discuss background as well as differential diagnosis, syndromes associated with these tumors, imaging, surgical indications, surgical considerations, outcomes, as well as presenting a brief algorithm and concluding with some notable case examples. Background and differential diagnosis. These tumors were first described by Sir Victor Horsley in the performance of a thoracic laminectomy in 1887. Our standard differential diagnosis for these tumors include meningiomas of the spine, nerve sheath tumors, specifically schwannomas and neurofibromas, and in the setting of phylum terminale tumors specifically, two additional considerations are myxopapillary ependymoma and paraganglioma. These tumors are associated with distinct syndromes, notably neurofibromatosis type 1, neurofibromatosis type 2, and in the case of spinal schwannomas specifically, schwannomatosis is a genetic syndrome that can be associated with those tumors specifically. In regards to imaging, MRI with contrast remains the gold standard imaging modality for intradural pathology. In the case of intradural extramedullary tumors, it is no different. MR imaging shows an intradural lesion with a dural tail displacing the cord. In the case of schwannoma, they are similarly homogeneously enhancing. However, they are often seen to involve a nerve rootlet and may involve the foramen and even have an extraforaminal component. A characteristic dural tail is not seen as distinct from spinal meningiomas. Myxopapillary ependymoma is almost exclusively seen in the lumbar area and is characteristically homogeneously enhancing with a elongated, almost sausage-like shape noted to displace the cauda equina within the dural compartment. Surgical indications for these benign tumors tend to be quite clear. Rapidly growing tumors or tumors causing neurologic symptoms warrant surgical resection. Surgery is not pursued, however, for diagnosis alone, and characteristic lesions with characteristic appearance on MRI may be observed with watchful waiting and serial MRI. A notable exception are midline cauda equina lesions, in particular myxopapillary ependymoma, as there is a concern for cerebrospinal fluid seeding and spread. In particular, in syndromic patients, the goal is to minimize lifetime surgical burden, and the conservative approach applies. Most intradural extramedullary tumors can be resected via a straightforward posterior midline incision and laminectomy, with or without some manner of posterolateral extension, including a transpedicular approach, all the way to a lateral extracavitary approach. There are some exceptions. Ventrally situated tumors in the cervical spine may be amenable to anterior cervical corpectomy. In the thoracic spine, anterior approaches are less feasible, but lateral extracavitary, as mentioned above, or even transthoracic retropleural approaches are an option. In the lumbar spine, because retraction of the cauda equina is feasible, generally posterior approaches are suitable even for anteriorly situated lesions. Oftentimes, in the case of meningiomas, dural resection is difficult, and dural cautery with bipolar electrocautery suffices. The use of electrophysiology is common, for all lesions in the intradural component, though debates about whether or not it ultimately proves useful and should be standard of care remain. In terms of outcomes, when a gross total resection is achieved, surgical outcomes for these lesions are quite good. In the case of both meningioma and nerve sheath tumors, gross total resection is associated with favorable oncologic outcome. In the case of myxopapillary ependymoma, a piecemeal or subtotal resection is associated with a higher recurrence rate, as opposed to an en bloc resection where the lesion capsule is not violated. When the capsule is violated, there has been reported association with an increased incidence of CSF dissemination and/or mortality. We now present a brief algorithm for the treatment of intradural extramedullary tumors, acknowledging certainly that every patient is different and ultimately surgeon's judgment as well as the interdisciplinary team's judgment should win the day in care of each individual patient. The initial approach is often determined by whether or not there are symptoms and/or a lesion is rapidly growing. In the case of asymptomatic or incidental findings, if the tumor is not a midline cauda-equina lesion, observation with serial imaging is appropriate. However, in the case of rapidly growing or symptomatic lesions or midline cauda-equina lesions, surgical resection is favored. If lesions are ventral and midline in the cervical or thoracic spine, or if they have a large extradural component, staged or combined procedures utilizing anterior cervical or lateral thoracic approaches may be called for. In the case of lesions that are not ventral and in the midline, for the vast majority of cases, midline posterior approach, with or without some form of lateral extension, is usually sufficient to address intradural extramedullary tumors. Surgical resection is performed and subsequent therapy is often determined by whether or not a gross total resection is achieved. If a subtotal resection is performed, depending on the lesion pathology, subsequent adjuvant radiotherapy, in the case of midline cauda-equina lesions in particular, or a course of watchful waiting may be appropriate. If, however, gross total resection is achieved and subsequent pathology reveals a malignant histology or a diagnosis of myxopapillary ependymoma, even in the case of a gross total resection, adjuvant therapy may be required, again, IMRT in the case of myxopapillary ependymoma. However, if gross total resection is achieved and the patient has a benign histology, and additionally, following any adjuvant radiotherapy if called for, serial imaging after the acute treatment phase is completed is always recommended to surveil for potential recurrence of the disease. Now we focus on 3 separate case examples and illustrations. In our first case example, we present the gross total resection of a thoracic meningioma. Patient's chief complaint is bilateral lower extremity weakness. In this instance, we have a 69-year-old male who presents with gait instability and infrequent falls, as well as some interscapular and bilateral flank pain. On exam, significant for hyperreflexia in the bilateral lower extremity, as well as a Romberg on exam. MR imaging shows an intradural lesion with a dural tail displacing the cord at the T6-7 level. The lesion is ventrally situated, but has a lateral extension. The differential for all lesions is broad. Myxopapillary ependymoma and paraganglioma are lower in the differential, given our thoracic location. The remaining possibilities, given the dural tail, meningioma is favored. Management strategy, we have a symptomatic lesion, thus surgery is favored. In terms of approach, as is the case with most of these lesions, a posterior midline approach is feasible. Though this lesion has a ventrally situated dural tail, there is sufficient lateral extension of the tumor and concomitant displacement of the spinal cord to the contralateral spinal canal such that a standard posterior midline approach should be sufficient. The surgical plan involves general anesthesia, neuromonitoring, placement of the patient in the prone position, standard midline thoracic exposure with intraoperative fluoroscopy for localization, given the common occurrence of poor localization in the thoracic spine, followed by a 2-level laminectomy and confirmation of the lesion before dural opening with intraoperative ultrasound. This is followed by microsurgical resection with the use of an operative microscope, midline durotomy, ultrasonic aspirator, and coagulation of the dural base. Standard closure is then performed. This patient was admitted to the floor postoperatively, fully removed postoperative day 1 without urinary retention. Given satisfactory dural closure, no bed rest was prescribed, and the wound remained clean and dry throughout the hospital course. The patient was subsequently mobilized with physical therapy and occupational therapy and discharged home on postoperative day 2. At 2 and 6 week follow-up, the patient had improved ambulation and lower extremity sensation. Key take-home points for surgical resection, spinal meningioma. They are most common in the thoracic spine and in middle-aged women. Neurofibromatosis, 2 in particular, can be associated with multiple cranial as well as spinal meningiomas. Watchful waiting is reasonable, except in the face of progressive neurologic deficits or rapidly growing lesions. And complete resection is most often feasible through a posterior approach. However, resection of the dural base may be challenging in anteriorly situated lesions. Thus, dural coagulation might be best employed in these situations. Now we present the gross total resection of a thoracic schwannoma. The patient's chief complaint is ataxia. We have a 65-year-old man presenting with progressive difficulty with ambulation and some mid-back pain. On exam, he has normal bulk and muscle tone in both upper and lower extremities, but hyperreflexia in both legs, along with a Romberg. His imaging and MRI, T1 post-contrast, again is suggestive of an intradural extramedullary lesion. Meningiomas in the differential, but given the absence of a dural tail and slightly more elongated and less tapered appearance, can suggest, and in this case does suggest, schwannoma. Our differential diagnosis, given the location, myxopapillary ependymoma and paraganglioma are quite low, but as always, neurofibroma or schwannoma or meningioma are considerations. In this case, our lead differential is schwannoma. Again, we have a patient who is symptomatic with focal neurological deficits. Thus, surgery is the treatment of choice and is favored. In terms of approach, as with the prior case, the lesion is occupying some of the ventral portion of the canal, but is eccentric to the left and displacing the cord to the right, making it favorable for, as with many of these lesions, a traditional posterior midline approach. Our surgical plan, general anesthetic, no paralytics given the need for neuromonitoring, motor evoked potentials, SSEPs and EMG, a standard midline thoracic exposure, again using fluoroscopy to ensure accurate localization, a 2-level laminectomy encompassing the lesion location confirmed on intraoperative ultrasound prior to durotomy. Microsurgical resection of the lesion proceeds using the operative microscope and a midline durotomy. Ultrasonic aspiration is involved in debulking the tumor, and given the thoracic location, sacrifice of involved nerve roots. Standard closure with Duracell. Our postoperative imaging reveals gross total resection of the lesion, here in axial cuts, followed by pre- and postoperative sagittal images, again showing gross total resection. The patient's hospital course, neurologically intact postoperatively. Bed rest for 24 hours in the case of this patient, with head of bed at 30 degrees. Subsequently mobilized with physical therapy and occupational therapy. Discharge home postoperative day 2 with 2 and 6 week follow-up, showing improved ambulation and resolution of hyperreflexia. Take-home points for nerve sheath tumors. They're most often found in the thoracic spine, in an equal distribution between men and women, as distinct from meningioma, where women are more predominant. Neurofibromatosis type 2 is associated with multiple cranial and spinal neurofibromas and schwannomatosis with multiple schwannomas. Watchful waiting is reasonable except in the face of progressive neurologic deficits, which is the case in this lesion. Complete resection is often feasible through a posterior midline approach. Sacrifice of the involved nerve root can be guided by evoked EMG in cervical and lumbar cases where the nerve root is functional, or sacrifice can simply proceed without EMG monitoring or other electrodiagnostics in the thoracic spine, given low concern for the functionality of these nerve roots. Dorsal roots can be sacrificed at all levels. However, sacrifice of a ventral nerve root will always be guided by the functionality and level of the lesion and the expected neurologic deficit if sacrifice of a functional nerve root is involved. This can be guided by intraoperative electromyography. As a final case example, we'll present gross total resection of a myxopapillary ependymoma. Chief complaint in this instance was back pain. We have a 30-year-old male without significant medical history presenting with acute episode of back pain and a recent episode of gastroenteritis. Pain is described as radiating to his hips and posterior thighs. On exam, full strength in both arms and legs, no pathologic reflexes, and normal sensation. Imaging here is suggestive of myxopapillary ependymoma, less likely paraganglioma. There's a characteristic elongated, almost sausage-like appearance in the lumbosacral canal displacing the cauda equina nerve roots. As always, the differential is broad, and while the lumbosacral location does not exclude schwannoma, meningioma, or neurofibroma, it does bring myxopapillary ependymoma and paraganglioma into consideration. Given the morphology of the lesion, the elongated, sausage-like appearance, as well as the absence of a dural tail or prominent involvement of one of the neuroforamina, myxopapillary ependymoma leads to the differential. In a patient with active neurologic symptoms, if not focal neurologic deficit, surgery remains a consideration, as always. However, the presence of a midline, lumbar, intradural, extramedullary lesion with a high consideration of myxopapillary ependymoma demands a more aggressive course, and surgery is favored. In terms of approach, as previously stated, the majority of these lesions can be resected through a standard posterior midline approach. In the lumbar spine, this is all the more true as retraction of cauda equina nerve roots is possible, whereas in thoracic and cervical spine, the spinal cord itself limits such maneuvers. Traditional midline approaches are the treatment of choice for all lumbar, intradural, extramedullary tumors. This case is no different. Our surgical plan: general anesthesia without paralytic. Motor evoked potentials and SSEPs are not necessary in such a case, but as always, EMG, particularly given the concern for involvement of nerve roots, which may or may not be functional, is of great value. Patient is position prone, standard midline lumbar exposure. Intraoperative fluoroscopy is used here, though cross-table films are perfectly adequate given the lumbar region. 3-level laminectomy is performed from the conus to the caudal pole of the lesion, and again confirmed prior to durotomy with intraoperative ultrasound. Microsurgical resection is performed with use of operative microscope and a midline durotomy. The filum terminale is isolated above and below the lesion and confirmed not to be functional using EMG stimulation, allowing for en bloc resection of the lesion, followed by standard closure with Duracell. Postoperative imaging reveals gross total resection of the lesion. Patient was admitted to the hospital postoperatively without neurologic deficit, on bed rest with head of bed at 30 degrees for 24 hours, subsequently mobilized and discharged home on post-op day 4. 2 and 6 week follow-up demonstrated improved lower extremity pain without neurologic deficit. It was during this time that outpatient radiation therapy was arranged. As discussed previously, radiation therapy remains a mainstay adjuvant therapy for myxopapillary ependymoma, even in the case of gross total resection. IMRT is the favored treatment modality for radiation therapy. In the updated MD Anderson experience, comparison of patients undergoing surgery alone and surgery with radiation therapy, Patients with surgery and radiotherapy showed a significant improvement in progression-free survival rate as well as local control rate. A point that is illustrated once again in this slide. Take-home points. Myxopapillary ependymoma is at the top of the differential for lumbosacral intradural extramedullary tumors, in particular if they have a characteristic appearance. Upfront surgical resection is pursued out of concern for seeding of the cerebrospinal fluid, even in the absence of dramatic focal neurologic deficits. En bloc resection should always be pursued out of a concern for seeding of the intradural space, and adjuvant radiotherapy plays a role regardless of extent of resection.